All right, good afternoon, and thank you for joining us for the last concurrent session of the day. On behalf of the National Institute of Mental Health, I want to welcome you to help us finish the end of the day today. And hopefully so far, are folks having an interesting experience here? I see heads nodding. Okay, that's good. You're awake. Yes, good. We hope your first day is going well, and we're hoping that this last piece will provide a nice, like a final dessert for you for the day. We have 5 great presentations today to focus on early detection and prevention, and it's along the kind of the spectrum of mental health and autism. And our first 2 speakers are going to focus on early psychosis, and our final 3 speakers will be focusing on autism. So we've done some very interesting studies at NIMH addressing this, and everybody will be coming from various perspectives. But what I'm going to go ahead and do is I'm going to go ahead and turn this over to our speakers, and I make sure they'll stay on time, so this way we have an opportunity for questions from you at the end of the sessions, and then we can end on time and let you head out and continue discussions about the day. Thank you.
Great, thank you. So it's a pleasure to have the chance to talk with you all. I'm going to be talking about our updated report on outcomes and predictors in OnTrack New York, which is New York State's coordinated specialty care program for early psychosis. I'm Ilana Nassel, and I am presenting the work of our group headed by Lisa Dixon, and with colleagues from the OnTrack New York team and our colleagues at the New York State Office of Mental Health, and also in our biostatistics group at New York State Psychiatric Institute and Columbia. So this is really a collaborative effort that I have the opportunity to speak to. Do I need to point it somewhere in particular? Okay, there we go, great. Okay. So rationale, so why did we undertake this investigation? So coordinated specialty care for early psychosis, which is a multidisciplinary team-based approach using specific evidence-based treatments in a coordinated approach, has been spreading widely throughout the country over the last decade, and especially in the last 5 years since the conclusion of the RAISE studies and with the set aside in the mental health block grant providing funding for this service. That said, little is known about the outcomes and predictors of outcomes of coordinated specialty care in real-world settings that are not part of a research protocol. Our group recently published data on our first cohort, so on a group of 325 individuals, but there's need to see if the results remain consistent with an expanded cohort as we follow people over time, and we've had the chance to work with more people. So that's the context for the current investigation. Our objective was to evaluate patient outcomes and also predictors of the expanded cohort of participants in OnTrack New York, New York State's coordinated specialty care program for early psychosis in community settings. So in terms of inclusion criteria, OnTrack New York serves individuals who are ages 16 to 30 and have had a recent onset of a non-affective psychotic disorder, so an onset within the past 2 years. We included those in this study who had had at least one follow-up assessment. The data that I'm presenting here is collected for program evaluation and fidelity monitoring purposes. So these are people who are receiving clinical care. They're not enrolled in a research study. Clinicians provide data at enrollment and quarterly for participants, and then the data is de-identified when it's used for research purposes, as in this case. And I will say that the data we have is for people while they're enrolled in the program. So once someone leaves the program, we don't have data on them. And I can say more about that in a little bit. Enrollment took place between October 2013, and this cohort is followed through September 2017 across 19 sites. And so in the first data set that we had reported and was published recently, that was our first 10 teams. So this is as we've expanded the program. And just to give context, we now have 21 sites across New York State, but 2 are since this we sort of closed this data set. 2 have come on board in the past year. We looked at a number of demographic and clinical variables, which include age, sex, race and ethnicity, social and occupational functioning, highest education, medication adherence, suicidal and violent ideation and behavior, substance use, hospitalizations, and time to intervention. And by time to intervention, we mean the time from the onset of psychosis to enrolling in OnTrack New York. And then the outcomes we looked at are the Myrick-Gaff scores. So those are the Gaff scores separated for symptom scales, occupational functioning, and social functioning. Also education and employment status, and psychiatric hospitalization. Longitudinal models were fit for each outcome individually using generalized estimating equations with autoregressive correlation structure. Linear models were fit for continuous outcomes with model estimates interpreted as differences. Logistic models were fit for binary outcomes with model estimates interpreted as log odds ratios. Models contain the main effects of time, site, baseline of respective outcome, as well as demographic and clinical predictors concurrently. So the sample in this investigation was 634 individuals. The age range, sort of the majority are between the ages of 18 to 23, with a 14% under 18 and 18% older than 24. Mostly male, 73% male. Racially and ethnically diverse, so just over a quarter white non-Hispanic, just over a third black not Hispanic, 28.5% Hispanic. And then also in terms of socioeconomics, diverse as well, so 45% publicly insured, 42% with private insurance. Most of those with public insurance in New York State, that's due to poverty and not due to disability primarily. In terms of education status at enrollment, you can see that data here. In terms of time to OnTrack from the onset of psychosis, the mean is 7.7 months, median 5.5 months. So it's I would say relatively quickly from the time of onset of psychosis that people are being enrolled in OnTrack New York. So, just over half of that sample with less than 6 months from the time of onset to enrollment in OnTrack New York. There is that group of 21% who it's more than 1 year from the time of onset of psychosis to enrollment. We don't report on it here, but I can tell you from our program evaluation and fidelity monitoring that most of our referrals do come from clinicians. So the biggest referral sources from inpatient units, also significant referrals from outpatient mental health clinicians, and smaller numbers from other referrers or self or family referred. And so most outreach efforts at this point are targeted toward clinicians, but also some outreach done to schools and to colleges, and we have some web presence so that people can find us in other ways as well. 46% of the group is using substances. In terms of medication, I mentioned most people are clinician referred, so most people are on medication at the time of referral. This is a clinician report, their estimate of medication adherence, so that 72% were adherent to medication, 12.5% prescribed medication but non-adherent, 6% were not prescribed medication at the time of study entry, and 9% unknown. The suicidal ideation and behavior, this is in the 3 months prior to enrollment. So this is I think, quite significant. 29% with suicidal ideation or behavior in the 3 months prior to enrollment, and a quarter with violent ideation or behavior in the 3 months prior to enrollment. And these are the baseline characteristics in terms of our outcomes. So social functioning, relatively less impaired as compared to occupational functioning and symptoms. So the GAF social functioning score of 55.9 out of the 0 to 100 scale, occupational functioning 35, and GAF symptoms 31. In terms of school and work, 59% were neither in school or work at the time of enrollment, little less than 10% in work, only 26.7% in school only, and 4.6% in both school and work. And 75% of individuals had been hospitalized in the 3 months prior to enrollment with OnTrack New York. So these are our outcomes with regard to hospitalization and education employment. So that red line, which is the line going, yeah, that one, shows the drop in hospitalizations following enrollment. So you can see it's roughly 10% per quarter following enrollment compared to about 75% in the 3 months prior to enrollment. And this is quite similar to the data we had in terms of our first cohort. So we sort of, with the larger cohort, we're seeing similar results in terms of these outcomes. And then the blue line, which you can see here, about 40% were in school or work at the time of enrollment, and that goes up in, biggest increase in the first 3 months, an additional increase at 6 months, and then sort of plateaus. So it gets to roughly 75 to 80% enrolled in school or work by 6 months. Yeah, more on that in a little bit. I should say, I didn't describe the model much, and I gather many here may be quite familiar, but while we're talking about school and work, I should say part of our model is a full-time support education employment specialist whose job on the team is really to help people return to school and work. And I think the prominence of that role within the treatment model is likely a significant part of seeing these improvements in terms of school and work following enrollment. Okay, so here we look at the predictors of education employment. So the significant predictors here are age, so older age, less likely to engage in school and work, men, less likely to engage in school and work, Black individuals, less likely to be engaged in school or work. Those with longer time to enrollment, which is not the same as duration of untreated psychosis or DUP, but is probably has some relationship with that. So those who had a longer time from onset of psychosis to enrollment also have less engagement in school and work. And then those with more symptoms, I should say those with better symptom scores or fewer symptoms had better engagement in school and work. What's in green was not found in the initial study, and so this is now significant. So age, time to enrollment in OnTrack New York, and the symptoms, and those in yellow were found in the original study, but were not significant with this expanded cohort. And these are the predictors of hospitalization. So we see that those not prescribed medication were less likely to be hospitalized. Now, I think we need to, I should say more about it in the discussion, but I'm going to comment on it here anyway, I suppose. So this was a small group not prescribed medication at baseline, and in some ways they may be different from the vast majority of people who were prescribed medication at baseline, but more on that in the discussion. Suicidal ideation behavior and violent ideation behavior were predictive of hospitalization symptoms had in the initial study had been predictive but was not in this expanded cohort, interestingly. And these are the GAF scores and our results here, again, quite similar to what we had seen in our first study and being replicated here with the expanded cohort. So this blue line here is the GAF social functioning, the red line here is GAF occupational functioning, and the green line is the symptom scores. So you see improvements, especially, the most prominent improvement in the first 3 months, continuing to improve at 6 months, and then, relative plateauing following that. Predictors of GAF social functioning, men had lower social functioning scores. Those who were adherent to medication, as well as those not prescribed medication, had improved social functioning, and those who were in school or work at baseline also, that was predictive of improved social functioning. In terms of the predictors of occupational functioning, again, men, being male was predictive of lower occupational functioning. Being a college graduate was predictive of higher occupational functioning. Longer time to OnTrack New York was predictive of lower occupational functioning, and lower symptoms were predictive of better occupational functioning. Okay, I'm getting my move on. So predictors of symptoms were being adherent to medication or not prescribed medication. Longer time to OnTrack New York was predictive of worse symptoms. So we see significant improvement in outcomes, which are plateau after 6 to 9 months. There is a small group that 20 to 25% that don't engage in school or work by 12 months, and it raises the question for us, does that group need something different? How do we help improve education work outcomes in that group? We know that longer time to intervention predicts less engagement in school and work and lower symptom scores, so highlighting the importance of rapid access to coordinated specialty care. And then we see some racial and gender disparities, with Black individuals and men less likely to engage in school and work, men with worse social and occupational functioning, which warrants further study. So we also, struggling with, do gains persist following coordinated specialty care? What's the optimal length of treatment? Should or can the model be tailored to meet different needs of different groups? Limitations being no control condition and all ratings by clinical staff, and therefore subject to clinician bias. Okay, thanks.
Okay, good afternoon, everyone. Thanks for sticking with us through this last session. My name is Needham, and I'll be presenting on behalf of Rachel Lowy today to describe our collaboration that is using electronic self-report screening to reduce the duration of untreated psychosis. So some background that many of you are familiar with and that was just touched on. Earlier treatment for first episode psychosis is associated with better long-term outcomes. When we look internationally, consensus really shows that a duration of untreated psychosis of less than 3 months is optimal for outcomes. But here in the United States, sadly, many individuals can take a year or more to get to appropriate treatment. And our work in this area really started to think that maybe extended DUP is associated with system delays in identifying and engaging individuals. So what we designed was a 2-phase cluster randomized controlled trial to test 2 specific interventions to reduce DUP. The first of those, we wondered, could we just increase the rate of case identification